Assalamualaikum warahmatullahi wabarakatuh. Today we would like to present regarding the herniated nucleus purposes HNP pathology for case presentation 2. My name is Anis Nanda binti Hasim and my group members are Fatih Shakira binti Muhammad Saleh and Aisyah Shamimi binti Muhammad Razmi. Okay, the table of contents consists of definition and significance of terms, description on the pathology, procedure used and justification, technique used, role of imaging, complication, pre and post procedure care, and lastly is the other specialized imaging. Okay, the first part is definition and significance of terms. Okay, insidious onset. Insidious onset is about any disease that develops slowly and gradually without symptoms. And the significance of insidious onset is time pattern of symptoms. And the second one is the lower back pain. Lower back is the lumbar region between L1 to L5. And low back pain is a pain that occurs posteriorly in the region between the lower rib margin and the proximal teeth in the lumbar region. And the significance of the lower back is supports the weight of the upper body, and the lower back pain is one of the symptoms of herniated nucleus purposes. Okay, next is stiffness. Stiffness is the condition of difficulty in moving, and the significance is stiffness is one of the symptoms of herniated nucleus purposes. Then numbness. Numbness is loss of sensation, weakness, or paralysis in standing and walking. Significance is it is also one of the symptoms of herniated nucleus purposes. Alright. First, 1 year. 1 year is refer to the duration of lower back pain occur, and they have two types, which are acute and chronic. Acute low back pain is lower than 6 weeks, while the chronic low back pain is more than 3 months. Alright, then restricted range of movement of lumbar spine. Limitation in mobility, especially during bending or flexion. And the significance of restricted range of movement of lumbar spine is to allow the pupil bend, erect slightly and improve the motion. This is the significance of lumbar spine. Alright, next are the herniated nucleus purposes. Herniated nucleus purposes refer also called lumbar disc herniation, slip disc, or spinal disc herniation. And HNP is extrusion of the nucleus purposes intruding into the lumbar spinal canal. And the significance of HNP is one a pathology, a spine pathology, and frequent cause of lower back pain. Okay, this is the image of the herniated nucleus purposes. Okay, we can see that herniated nucleus purposes locate between two vertebra, between each vertebra, and located at the intervertebral disc. Okay, next we move to the Fatih Shakira.
The second section of these slides, which is the description of this pathology. First of all, what is herniated nucleus purposes? It is said here, a herniated disc is when vertebral discs start to degenerate or are damaged from various causes, and the center of the disc will rupture through its outer ring. Moving on to the epidemiology of this pathology. The incidence of a herniated disc is about 5 to 20 cases per 1,000 adults annually, which is around 25%, and is most common in people in their 30s until 50s, with a male to female ratio of 2 to 1. The estimated prevalence of symptomatic herniated disc of the lumbar spine is about 1 to 3% of the patients. The prevalence is most significant among 30 to 50-year-olds. The patients, meanwhile, the patients between 25 to 55 years old have an approximately 95 chance of herniated disc that occur either at L4 to L5 or L5 to S1. The pathophysiology of HNP is believed to be a combination of the compression of the nerve by the bulging nucleus pulposus and the local increase in inflammatory chemokines, which initiates the inflammatory response and to regulate the host defense against pathogens, mediating the innate immune response. A tear can occur within the annulus fibrosis here, and then the material of the nucleus pulposus can leak through the tear that occurred earlier. into vertebral or vertebral foramen. And the changes consist of nuclear degeneration, nuclear displacement, and stage of fibrosis, which is the thickening or scarring of the tissue. Figure 5 here shows the different approach to lumbar punctures. A figure shows an outline of the spinous process centrally on the fluoroscopic view. Meanwhile, B figure shows the course of the needle that can be followed into the spinal canal on lateral view. Meanwhile, C figure shows the oblique interlaminar approach. Next is figure 6, shows the confirmation of successful intrathecal subarachnoid contrast injection. The initial traced contrast injection to cross double lateral views should be able to demonstrate flow of the contrast away from the needle tip with thin layering on the dependent ventral aspect of the spinal canal at the arrow here. These are the causes of herniated disc, which includes aging, sports trauma, automobile accidents, foot-related injuries, and carrying heavy stuff or improper lifting. Proceed with the implications. The first implication of this pathology is cauda equina syndrome, which is caused by the severe compression of the nerve roots in the thecal sac of the lumbar spine, and it most commonly due to an acute lumbar disc herniation. In this figure 8, it shows cauda equina syndrome that can be seen on MRI scan. A herniated disc, the pointing arrow here, is compressing the cauda equina. Number 2 is chronic back pain. For example, arthritis of the spine. It is the gradual thinning of the cartilage inside the spine. Number 3 is permanent nerve injury that can occur. For example, spinal stenosis, which is the narrowing of the spinal canal that may lead to nerve pain. And number 4 is paralysis that is due to nerve damage or injury. In some cases, HNP may not show any symptoms at all. However, if there are any presence of symptoms, it can be tingling, numbness, sciatica pain, back and neck pain, and weakness. Next, we will talk about the third section, which is the procedure use and the justification. We decided to use myelography, which is the imaging examination that involves the introduction of a spinal needle into the spinal canal and the injection of contrast media into the space around the subarachnoid space by using a real-time form of X-ray. In this case, we use digital fluoroscopy. The first justification of using this procedure is to pinpoint the size, structure, or location of the herniation. And number 2 is to collect cerebrospinal fluid, CSF, to detect if there is any infection or disease. Some of the criteria that can be evaluated from the CSF obtained from the patients are the appearance or color of CSF, and then the glucose level, protein level, and white blood cells count.
Next, we move to the appropriate technique used from the specialized procedure to show the pathology. First, for the positioning of patient, they are either sitting or in lateral decubitus position. The patient is to remain in the fetal position with neck, back, and limbs held in flexion. The lower lumbar spine should be flexed. The back is perpendicular to the edge of the table. Hips and legs parallel to each other and perpendicular to the table. Pillows are placed under the head and between the knees to improve patient comfort. This technique will promote widening of the interlaminar space. These are the standard equipment used. First, sterile cleaning solution, sterile drape and gauze, plastic tray, tubes, needles, manometer, extension tubes, local anesthetic, syringe, labels, and band aid. Next, for the aseptic technique, after patient is positioned in lateral decubitus, the back is cleaned using sterile cleaning solution, and then anesthetic is injected. Suitable one is used in order to avoid allergic reaction. We move to the procedure. First, insert a thin, hollow needle at interspace L2, L3. The needle and stylet inserted into subarachnoid space, and the position is confirmed by fluoroscopy. The stylet is then removed. Free flow of CSF from the needle shows that the entry is successful. Small sample is collected for analysis. Then, replace the amount of CSF removed with equal amounts of contrast media to maintain stasis. Patient is tilted slightly to the feet to allow for pulling of the contrast. in the subarachnoid space below the L1. Radiographs image are then taken, usually in semi-erect position. Fluoroscopic imaging is a real-time visualization of body structure. It can monitor contrast media flow, and it has image intensifier, footboard, and shoulder guide. The table can be tilted foot down to move contrast media within subarachnoid space. It can capture image and have post-processing for edge enhancement. For the contrast media, positive water-soluble non-ionic contrast media is used. Positive contrast media will flow with effect of the gravity, and water-soluble gives excellent visualization of the nerve roots and rapidly absorbed from subarachnoid space into the bloodstream. Non-ionic is more commonly used and cause less irritation compared to ionic. The osmolarity is similar to CSF and limit movement of the patient to prevent its dilution. Patient also need to be fully hydrated to prevent possibility of any side effects. It have rapid reabsorption rate, so the procedure cannot be delayed, and the dosage is approximately 6 to 17 milliliter. We will move to the next section. First, role of imaging in pathology evaluation. It is to visualize the pathology. It can assist in pathology diagnosis and plan for further action and treatment of the patient. Next, the information obtained for further management of patient. First, we can observe anatomy and structures condition from the radiograph. For example, the condition of vertebral disc. Next, we can diagnose disease based on CSF testing, based on the color, clarity, pressure, and many other aspects. Normally, CSF color is clear and colorless. If it is yellow, pink, or orange, it shows red blood cells breakdown due to bleeding or presence of bilirubin. If it is green, it shows infection or presence of bilirubin. Turbid or cloudy shows high white blood cell or infection. And if it is red, it shows hemorrhage or blood vessel puncture. There are a few complications that might occur from this procedure. First, headache, which are more frequent in females, and then nausea, slight or temporary increase in lumbar or sciatic pain, convulsion, and hypotension. These complications are rare with low neurotoxic contrast media.
Next, we move to the pre and post-procedure care. For the pre-procedure care, patients is advised to increase the fluid intake before the day of the procedure as it is important to be well hydrated. Second, patients must not eat any solid food for hours before the procedure, but for the fluids, it must be continued. Third, patient change during the procedure, patient change into the hospital attire. We must ensure that the attire is bed open gown. Fourth, inform the consent to the patient, and then doctor must be explain the procedure to the patient before the examination, and lastly is screening for the contrast media sensitivity. Then we move to the post-procedure care. Firstly, patient need to stay rest on the bed for 24 hours after the procedure, and then head need to slightly elevate. Drink plenty of water to flush contrast media out of body. Then the patient need to inform the doctor of any sign of infection at the puncture site or any post-procedural symptoms like nausea, vomiting, and headache. Next, we move to the other specialized imaging. Why we need to use advanced imaging in the diagnosis and treatment? Firstly, to assess nerve root compression due to disc herniation or spinal stenosis and caudal equina syndrome. Second, to identify the affected disc level before the surgery. Okay, then we move to the first specialized imaging, which is magnetic resonance imaging, MRI. MRI can be used if problems such as infection, inflammation, disc herniation, or rupture, or pressure on a nerve is suspected. The advantage of the MRI, no ionizing radiation use. Second, good visualizing of soft tissue because it can differentiate soft tissue damage, including disc, ligaments, infection, and tumors. And disadvantage of the MRI is lower spatial resolution. The cortical bone lesions are not as well as visualized. Second, claustrophobia. Third, longer scanning time needed. And fourth is contraindicate in the presence of a ferromagnetic substance, such as pacemaker, aneurysm, cochlear implant, spinal cord stimulator at the patient. So, if you sure that patient don't use any ferromagnetic substance, so the MRI can be used during the procedure. This image shows the herniated nucleus purposes by using the MRI. Okay, and the arrowhead is denotes the herniation at the L4 to L5 level. Then this image is from MRI scanning, shows a herniated disc in the lower back. Okay, and the disc is bulging out toward the spinal canal, putting pressure on the spinal cord and nerve roots. Next, the image of A is sagittal lumbar spine from MRI, and B is the axial lumbar spine by MRI at L4 to L5. Then the second imaging is computed tomography scan, CT scan. The advantage of the CT scan is can detect bone structure problems, the facet joints and the posterior elements of the spine, disrupture or spinal stenosis. Second, the time of procedure shorter compared to the MRI. Third is less sensitive to patient movements. Disadvantage of CT scan is use ionizing radiation. Right. This image shows the axial and sagittal image demonstrating a large left-sided eccentric disc protrusion at L4 to L5. Okay. That is comprising the traversing left L5 nerve root. Okay. Here the reference that we use from the books and also articles. And that's all from our group. Thank you.